Hello and welcome everyone. My name is Hayaatun Sillem and I'm the Chief Executive of the Royal Academy of Engineering. And on behalf of the Academy, I'd like to welcome you all to the first in our new series of critical conversations. Over the next few months, we've lined up some exceptional engineers for fireside chats to explore and debate issues of critical importance to the global engineering community. Starting with today's event on the vital role of engineers in pandemic response and preparedness. And I'd like to welcome our first guest to the Virtual Academy Fireside, Professor Sir Richard Feachem and Dr. Nitesh Kumar Jangir, both of whom have been involved in different ways in the global fight against COVID-19. As we're all painfully aware, the human and the economic cost of the virus has been just staggering. And of course, as both of our guests will tell us, we are very far from finished with this pandemic. But the photo last week of 90-year-old Margaret Keenan from Coventry in the UK receiving the first patient dose of the Pfizer-BioNTech vaccine does, I think, for many of us feel like at least a turning point in the fight against the virus. And it also gives us the opportunity to turn our gaze further afield and look beyond our national emergency to the broader international context, which is where our focus is going to be tonight. In particular, we'd like to look at how the pandemic has played out in low and middle income countries, and to talk about what the key issues are going to be in lower income countries as vaccines are gradually rolled out. And more generally, with the festive season now in sight, I think it's also a great time to reflect on our experience of this year as a whole, to ask, what has the engineering community learned from how we've responded to this virus? To see how we can draw on our experiences to ensure that we're better organised and more resilient in the face of future shocks. To ask whether we can take away any broader lessons about how engineers can and should work with other disciplines, with policymakers, business, civil society, to tackle these shared challenges. And it's my pleasure and my privilege to be joined by two exceptional engineers who are extremely well placed to explore these issues in detail. Firstly, I'd like to introduce Sir Richard Feachem, the Professor of Global Health at the University of California, San Francisco, the University of California, Berkeley, and Director of the Global Health Group at UCSF Global Health Sciences. Sir Richard has had an extraordinary career in global health. He was founding Executive Director of the Global Fund to fight AIDS, TB, and malaria, and grew it to become the world's largest health financing institution for developing countries. He's been a Director for Health, Nutrition and Population at the World Bank, and he's been Dean of the London School for Hygiene and Tropical Medicine. Most recently, he's been leading an initiative with the Lancet Medical Journal to eradicate malaria by 2050. So Richard is a Fellow of the US National Academy of Medicine and of this Academy, where he's also a member of the steering group for our Engineering X Pandemic Preparedness program, which looks specifically at what we can learn from this crisis that we've all been living through this year. Joining Sir Richard is Nitesh Kumar Jangir, an engineer and entrepreneur from Bangalore whose innovations have been successfully used in the fight against COVID. Nitesh is the co-founder of Coeo Labs, where he's used his skills in embedded systems design, to develop a number of patents in the area of medical devices and AI. He's a Commonwealth Innovation Awardee and an alumni of the Academy's Leaders in Innovation Fellowships Programme, which supports engineering entrepreneurship in 15 partner countries. Perhaps his most prominent innovation to date has been a low-cost breathing support device for premature babies. When COVID-19 arrived in India, Nitesh was inspired to build upon this innovation to develop a breathing aid for the worst-hit patients, and he's going to tell us more about this later. The Academy is very proud to be supporting Nitesh as part of its Engineering X Pandemic Preparedness Grants Programme. But let me turn to you first, Sir Richard. Perhaps it's not surprising that many of us have looked at the COVID-19 pandemic primarily through the lens of our own country or maybe even our own community. But can you please give us an overview of how the fight against COVID is playing out around the world?
Well, good afternoon, or we're in San Francisco here, so it's good morning. And thank you for this invitation. And Nitesh, nice to meet you and discuss these issues with you as well. For the last 10 months, we've been deluged on a daily basis by information and speculation about COVID-19. And it's useful to stand back and look at some big picture realities, particularly big picture realities which have strong implications for what we should do next and what our agenda for action should be going forward. And I'd like to quickly mention 4 of those. The first one is to just remind ourselves that this pandemic was entirely predictable and frequently predicted. And not just predicted in general terms, we're going to have a pandemic, watch out, but predicted much more specifically. We knew it would be a respiratory virus. We knew it would originate in wild and or domestic animals. We knew that it might well be a coronavirus. We knew that it would spread worldwide within 15 or 20 weeks. And we knew that the economic consequences would be measured in trillions of dollars. But despite this prior knowledge of what was going to happen, we didn't know when, we were almost totally unprepared. And we seemed to be surprised and confused and slow moving. And all the preparation that was being called for by people who predicted this was just not put in place. And I think the big implication of that is preparedness for the next pandemic. And we'll say a bit more about that later in a moment. But also, I think there's implications for climate change because we are to some degree sleepwalking into a catastrophe with climate change. And I think COVID-19 tells us that that's a really bad idea. We should be far more prepared and taking far greater action. The second big reality I'd like to mention is that there are large differences between countries. We haven't all been affected equally. The mortality rate from COVID-19 in the UK is 3 times higher than in Germany. Germany is having some current problems, but nonetheless, the UK has a mortality rate from COVID that is 3 times higher. The mortality rate in the UK is 50 times higher than Japan, 50 times higher. And it's 100 times higher than South Korea. And it's 1,000 times higher than Taiwan. These are massive epidemiological differences, and they do not appear to be explained by the biology of the virus or the biology of the human host. They appear to be explained by leadership, policy, execution of that policy, and compliance and cooperation by the general population who either are or are not willing to follow guidance given by their government. And some countries have got this right, particularly the countries of East Asia, and some countries have got this wrong, such as the UK and the US. And that difference translates into tens of thousands of lives that could have been potentially averted. So the implication here is that we are not powerless. We can do this much better, and we need to do it much better in connection with the next pandemic, preparedness for the next pandemic. My third big picture reality is that, Hayaatun, as you mentioned, we've got a long way to go. In the last week or so, a number of senior figures in the US and the UK have said that we're at the beginning of the end. Well, I think harking back to 1942 and Winston Churchill, it would be more accurate to say that we're at the end of the beginning. This has got a long way to run. And let me illustrate that with 3 quick points. Firstly, the current estimate of cases globally is about 75 million. Now, thought experiment, suppose that's a 10-fold underestimate. Suppose the real number is 750 million. That still leaves 90% of the population of the world, or 7 billion people, uninfected, immunologically naive, having not yet met this coronavirus. So the coronavirus has got a big smile on its face. It's got a long way to run. It's got 7 billion susceptible individuals still to potentially infect. Secondly, while the rollout of the vaccines, which we're very excited about, may proceed within 2021 in wealthy countries such as the UK or the USA, achieving high vaccination coverage worldwide will take years, and we have got to be preventing sickness and death during that substantial period of time before we achieve global high immunization coverage. And the implications of all this, I think, are no complacency. Let's just sit around saying problem solved because we're rolling out the vaccine, but let's take the action that we need to reduce sickness and death while the immunization coverage is increasing. And the last point that I think I'd like to emphasize is that we should see this as a dress rehearsal. There will be further pandemics, and those pandemics of the future could be much worse than the current pandemic. The current pandemic is caused by a coronavirus with a modest R value. The reproductive rate is not low, but it's not very high either. It's a modest value. And the case fatality ratio of this coronavirus, the proportion of people who are sick who end up dying, is also modest. If we had another pandemic in a few years' time or whenever, where the value of R was closer to that of measles, and the value of the case fatality ratio was closer to that of MERS, the Middle Eastern Respiratory Syndrome, which, by the way, is caused by a virus very like the virus that causes COVID-19, then it would be truly devastating. We'd have a pandemic which would make this one look relatively minor. And I think the implication there is preparedness, that as we fight COVID-19, we've got to be constantly thinking about the technologies, the science, the international collaboration, the systems which we need to be putting in place, not just for COVID-19, but to be better prepared for the next one. Now, all that sounds a bit gloomy, and my intention is not to be gloomy this morning. The sun is shining in Northern California. But my intention is to be clear-sighted, because I think unless we are clear-sighted, we won't get the next steps right, and we won't have the right agenda for action going forward.
Well, Sir Richard, thank you for your very helpful, if somewhat sobering framing. We'll come to some of those longer-term issues that you raised very shortly. But first of all, I'd like to say, well, if this is the end of the beginning, what should leaders around the world be focusing on over the next year if we want to give ourselves the best chance of overcoming this virus? And in particular, where does the engineering community come in?
Well, that of course is the great question. What should we be doing, and particularly what should we be doing that we're not doing at the moment? Responding to COVID-19 is very complex, and I find it useful to sort of organize thinking into three domains: hardware, software, and international collective action. In the hardware category, we have got diagnostics, drugs, vaccines, and all manner of equipment, medical equipment and protective equipment. And we'll hear more about that from Nitesh in a moment. But if we look at vaccines, drugs, and diagnostics, on the vaccine front, the news is spectacularly good, as we're all aware. The first vaccine is rolling out, a second one will start rolling out very soon. There's a third one coming along close behind, and there may be a fourth and a fifth. So we've made spectacular progress on the vaccine front. Diagnostics, good progress. We've got close to what we need now, a bit of fine tuning still required. And I think the challenge on diagnostics is more how to use them purposefully and how to make the data collected really influence policy and decision-making rather than discovering diagnostics, which we've largely got. On drugs, the progress has been much more modest. We need drugs to prevent infection, prophylactic drugs. We need drugs to treat mild infection in the community. And we need drugs to keep severely ill patients alive in hospital. And at the moment, we don't really have much progress on any one of those fronts. So there's a big priority in drugs to do more and to do better quickly. Coming to software, which is really about behavior and the prevention of transmission, masks obviously are center stage, masks, and we still struggle worldwide to achieve a sufficient level of mask wearing when people are out and about. Social distancing, hygiene, what kind of events to avoid, what kind of gatherings not to allow, and of course, testing, tracing, quarantining, those package of measures, which, if successfully designed and implemented, can substitute for lockdown, measures which can bring the value of R to less than 1 and cause the numbers to decline without having to shut down the economy or close schools. So I think there's a lot of work to be done on the one hand, rolling out the vaccine energetically, but on the other hand, doing all those other things, which are largely in the software category, which keep R below 1 without damaging the economy too much and keeping schools open. The last heading, international collective action, I think is extremely important, and particularly for the low and middle income countries. The COVID-19 pandemic is an archetypal global public bad, and fighting the pandemic is an archetypal global public good. And we have seen too much nationalism, I think, around the response to COVID-19, and not enough international collective action, which we really, really need. This is something where we're all in it together. All countries are in this together. No country can be an island or isolate itself from the consequences. We all sink or we all swim. And there is one outstanding example of international collective action, which is COVAX, the program led by Gavi and CEPI and WHO based in Geneva, which is doing remarkable work in developing, procuring, and distributing vaccines worldwide in a way that benefits all countries and is equitable. And we need to really support COVAX. Hopefully the United States, which hasn't yet joined, will join on January the 20th. The UK has joined, which is great. And COVAX, I think, is a shining example of the kind of international collective action that can really make a difference, and we should build on it and replicate it. So those are just a few ideas for the immediate agenda.
Wonderful. So Richard, lots of rich material there that we will come back to mine when we get into the questions and answers with the audience. But first of all, I'd like to turn to Nitesh. At the time the pandemic broke out, you were a successful engineering innovator working in Stanford, working in India. Tell us a bit more about your background as an entrepreneur.
Yeah. First of all, thank you, Hayaatun. And it's always great to hear Sir Richard, as you correctly said, that's such a fine-tuned information which we can all take home and use it to design our policy, design our next steps. My background, I was born in a village in a state called Rajasthan in India, where the nearest hospital from my village was around 20 kilometers away. And it was not just a hospital, it was a primary healthcare center. And the nearest hospital where super specialty or critical care was available was 120 kilometers away from my city. So during my childhood, I always seen people around me losing their life because they don't get timely access to health care. And that's where I had this thought of becoming doctor, but I wasn't that intelligent enough to get into a med school. So I took an easy path and said, okay, I'll rather become an engineer. So I got into engineering school. I did electronics engineering, but then because I always had passion for biology, and I had a really good school teacher who taught me biology using physics. So he used all the concepts of physics and how it plays out in biology, and that's where my interest of using engineering in using medicine got into the picture. Most of my projects or research during my undergrad was into medical devices, into medical sciences. Post that, I joined the company. I was largely working in defense research, and after that, again, I got opportunity to met another good mentor of mine, Dr. Rakesh. He pushed me to a program called Stanford India Biodesign Program, which was a tri-university program between Stanford, IIT Delhi, and AIIMS, where they train engineers and doctors on how to work together, which was quite eye-opening for me because we, especially in India, as engineers, we have a lot of great engineering schools, but we work in isolation. So we do not work with we do not have interdisciplinary engineering schools here. I thought that okay, being a good research program, they will teach me more and more of engineering. But then I remember my professor, Dr. Balram Bhargav, who is now chief of ICMR in India, told me this thing that I know you are a good engineer, and he told doctors, I know you're good doctors. I'm not going to teach you how to become better doctor or engineer. I'll teach you how to use your existing knowledge in best way to solve the most critical unmet clinical needs. So that's where my journey of solving unmet clinical needs in the field of medical sciences started. I developed a product during when I was studying at Stanford India Biodesign Program to tap out extra fluid from lungs using a low-cost disposable part, which we licensed out to a manufacturing company. Post that, again, because I started enjoying it more, I started learning it more, that how need-based innovation can really not just impact people, but also can be a good career going forward. So I started this company called Coeo Labs, where we develop new medical devices in the field of emergency and critical care, and then we take them forward to the people who really need them, not just in India, but in India, sub-Saharan Africa, as well as in countries like UK and US.
Wonderful. Well, I will resist the temptation to comment on your explanation as to how you became an engineer, but I will say that you're a great example of how engineers are wonderful collaborators in supporting advances in the field of medicine, and a brilliant illustration of how engineering is a really high social impact career. But take us back to the start of 2020, when we started to see COVID cases rising in China and Europe. Can you tell us about how you came to realize that this was something that you could play a role in responding to?
Yeah, this was quite interesting because we already had one innovation we were working, which was into respiratory care. So we have a product called VAP Care, which is world's only intelligent secretions and oral hygiene management. So it sounds so fancy. It's basically a device which senses and remove all the saliva and secretions in patients who are on ventilators, so they don't get secondary pneumonia because of aspiration of saliva. Because as we don't realize it, but we generate close to 1 to 1.5 liters of saliva every day, but we swallow all of it. Not even a drop of it goes inside our airway or inside our throat. When it try to enter, we cough it out. These patients who are on ventilator, they cannot do it. They cannot cough it out. So all this saliva and secretion slowly accumulate and reaches to the lungs and infect them. So we were because of this product, we were already working closely with the critical care community in India as well as globally, and I was really surprised at how much aware critical care community was with related to COVID, how they were up to date about the latest research, latest work was happening. And at that time, everybody started talking about, okay, it's in China, it will get contained in China, it may not come to India. Again, being in the supply chain side, we were looking at a lot of things where usually we used to get a lot of PPEs or a lot of medical supply coming from China to India, but suddenly we saw reverse. But then at the same time, we were looking at a really big horror, because if all of this is going back, going from India to China, then if COVID comes to India, do we have enough supplies? And that fear became reality when COVID actually hit India. We didn't have enough supply of masks. We didn't have supply of PP kits. We almost, because in India we import close to 75% of medical devices. So this wasn't the sector we were. Means we were dependent locally, and it became really a big nightmare. Masks which we used to get at say $0.01 one, we were paying $10 for the same thing, and that even then it was really hard to get a hand on it. So same time when we were working really closely with the doctors, they told, and everybody then started talking about ventilators globally, that we need more and more ventilators. But all the critical care doctors who were closely monitoring this, they said we don't need ventilators, because if a patient with this kind of infection and this kind of lung injury goes to mechanical ventilator, it's really hard to take them out. So this should be the last machine we need. What we really need is all other equipments which will ensure that no patient will get shifted to mechanical ventilators. So all the non-invasive ventilation techniques, whether it is CPAP, which is providing positive pressure from outside, whether it is high flow therapies, or whether it is BiPAP. So this was something we learned from doctor, and then we started working towards making solutions which will fulfill this need. And I'm happy to tell you now, we have been quite successful in doing that. We got help from Royal Academy of Engineering also to accelerate overall development of these innovation, and also to deployment of these innovations across India.
Well, you make it sound so simple. You spot the opportunity and then you go away and deliver your innovation. But of course, one of the things that's been absolutely astonishing is how much rapid innovation has taken place during this pandemic. So tell us a bit more about how it felt to be adapting your innovation, getting it into production at scale, getting it into hospitals, all the time against the backdrop of rising COVID cases. Tell us about what the particular challenges were you experienced and how you overcame them. And also, please do reflect on how it changed you as a person and an entrepreneur. What did you learn from that process?
Yeah, this is quite interesting, and so just to give you an example, where people are taking example of vaccines, that it takes usually 8 to 10 years to develop and test a vaccine. Even in medical devices, it takes, especially in critical care, it takes 4 to 5 years to develop a medical device which is into a high risk category and get it into the market. It took us 3 months this time. My last device, SaaS, which you already talked about, a neonatal breathing support equipment, which is world's only neonatal breathing support equipment, which can work without electricity, which can work without a trained person, and which can work in hospital as well as in any kind of transport. And for countries like in India or countries in sub-Saharan Africa, for us transport does not mean ambulance. For us transport means anything from a bicycle to a three-wheeler to a bike, anything. So we had experience in developing a solution in this area, and then we quickly used our same experience, and then built this device, because we again, when we were working really closely with the doctors, and we were working closely with people who are on ground, we were exactly able to understand what are the exact needs they have. We realize that those we cannot design a solution which is so complex to use, because one of the most important things we have realized after working for 5 years in this area, it's not about equipment. It's about the people who are using them. It's the biggest shortage we have seen right now, and even right now we are seeing in India, is not for the equipment. We are seeing is about trained people who can use this equipment, who understand what patient need, who can tune these. and also looking at the infrastructure to support these equipments. So it's not just that I can get a ventilator from GE and put them in tier 2 city of India, where we don't have all the supporting infrastructure of compressed gas, compressed oxygen, continuous supply of electricity, trained people who understand all those complex modes. So that's where we designed really simple to use product. We call it SaaS Pro. SaaS is a Hindi word for breathing. So we developed a single device which can deliver both CPAP as well as high flow nasal cannula or high flow therapy based upon the patient's condition. And along with that, we have developed this interface called SaaS helmet, which is the helmet interface for patients who are in COVID. So it basically isolates patients' full head itself, and then it provides the non-invasive breathing support. So by doing this, what it does, it will also ensure that caregivers are safe while they are delivering non-invasive ventilation. Because one of the reasons why caregivers were afraid of using non-invasive ventilation was aerosolization of saliva and secretion, which put them at really high risk. So if you have a fully enclosed environment around the patient's head, which is really comfortable to the patient while safe for the caregiver. So it took us figuring out the supply chain. Around most of our time actually went into figuring out supply chains, because those got broken. We got help from Indian government directly to get some stuff picked up from China. We had to move a lot of our supplies to India. We had to get emergency approvals, because then during that time lockdown was happening. Emergency approvals to get some specific suppliers run their shop. We had to get approvals for special flights to get materials in. So those were quite crazy, but again, quite satisfying time. But I would still say that whatever said and done, if we do what was supposed to be done in five years, in 3 months there would be shortcomings. So we see a lot of issues in field, but then now we are changing them a lot. We are fixing those problems a lot. And other big issue we see is that then in this kind of time frame, you cannot do all the complex regulatory testing, which is required for a proper medical device for long-term uses, to make sure a safe and effective use of a product. So many of those regulatory testing has to right now we have completed after 5-6 months, but we launched the product within 3 months. 3 months itself. Yeah, I think as an entrepreneur, one thing it has taught me that if there is a huge market pool, overall system you automatically get pulled together. The whole market dynamics changes towards solving that needs. Means earlier we never thought that these components, which are medical grade, we can get them manufactured in India locally, and just make the whole product locally made in India and supply to local population.
Wonderful, Nitesh. I mean, what an inspiring story, and really great example of user-centric, inclusive design. Congratulations and good luck with everything that's still to come. Now, I'm really keen that we're going to open up this conversation to audience questions and answers. So please type, if you've got a question, type it into the chat box, noting if your question is directed at either Sir Richard or Nitesh or both, and we'll get through as many as we can. So I'll just kick things off with an opening question for both our speakers. What has surprised you most, either in a good way or a bad way, about the global engineering community's response to the pandemic? And I'll start with you, Sir Richard.
Well, I think, yes, generally, there have been quite a number of surprises and things that we didn't expect, and there will be in the future as the pandemic evolves. I think a negative surprise that I would flag is the unwillingness of apparent unwillingness of European and North American countries to learn from other countries, particularly East Asian countries, about their successful responses. That has really surprised me, that we haven't in Europe and North America reached out and learnt more systematically from countries like Japan or South Korea and others, how they have kept their mortality rates so much lower than ours. On the positive surprise, it would have to be the vaccine story. I think within 10 months to have 2 vaccines using a completely novel and new technology that has never been used in a human vaccine before, and showing very high efficacy and good evidence on safety, I think that's just revolutionary. And it makes me think, if we'd applied a small fraction of that effort and ingenuity to some engineering tasks like the redesigning of masks, we would be a lot further ahead today than we are.
Absolutely, I think lots of us would recognise that. And Nitesh, over to you. What have been the surprises, good or bad, about the global engineering community's response for you?
Yeah, I think this is quite interesting. One of the biggest, I was the negative side of it. I was amazed how much disconnected engineering community and how much in shallow we are living from the medical community. Again, if I start with a lot of solutions which people were developing, a lot of DIY, a lot of in India we call it jugaad solutions, are popping up across the globe. 99% of them didn't make it to field because none of them were designed with doctors, none of them designed with people who are working in field. So a lot of efforts was put in, but it didn't result into solving real world problem. But on contrary to the same thing, I was again amazed, specifically with the real connected world, that how people across the globe, either it is from people from sub-Saharan Africa, East Asia, India, or North America, UK, Europe, how people were collaborating, commenting on solutions and fixing problems. Or there were a lot of good open source designs of complex devices, like ventilators, humidifiers, or all other medical equipment. That how a global community, which usually we have seen in open source software design, got into open source hardware design. I was really amazed with them, and even many of these solutions actually made it to field, and I've seen them working wonderfully and making COVID patients come out of this infection and go home safely.
Yeah, that spirit of collaboration has been a real revelation for many of us, I think. So one of the points, Nitesh, you just made has been picked up by one of the questions, and there are some great questions coming in. Please do keep them coming. So I'm going to put this to you, Sir Richard. The question is really about whether we need to create more institutional structures to support this bridge between engineering and public health. So obviously, there is collaboration going on, but do you think that whether it's institutions or learned societies or other forums, do you think we need more that formally brings those two communities together?
Yes, I sense that we do need more. I think the medical and the biomedical community, both nationally and internationally, are somewhat better organized than the engineering community, nationally and internationally. And of course, when we look at the development of hardware and software for pandemics, there's a big overlap between what the biomedical community does and what the engineering community does. And there's a large area where both need to be involved. And there are also large areas where engineers need to contribute engineering and bioscientists need to contribute bioscience. And I think we certainly haven't picked up those opportunities early enough. For example, we've known for quite a while that one of the vaccines that was going to be approved early would require storage at -80 degrees centigrade. Now, if ever there was an engineering challenge, it's a global supply chain at -80 degrees centigrade. That's quite a challenge. and more generally global supply chains with refrigeration, even if it's not -80 degrees centigrade. And work has been done on that, but I have the feeling those issues could have been addressed jointly by the two communities earlier on, and there could have been a much more forceful effort to solve that and other very predictable joint problems that we were about to face.
Yeah, I think actually that resonates with our experience in the academy, where we saw a sort of disconnect between the problems and the challenges that were experienced by public health professionals and those on the front line, and the skills and capabilities that engineers could bring to bear in interdisciplinary teams and contexts to help tackle those. And so I think there is definitely some sort of brokerage or improvement to that interface that we should look at. But I want to, sorry, I should have said that question also came from Adam Hawthorne from the biochemical engineer. And Nitesh, I've got one for you from Maha Hussain, who's a student at the University of Bath in the UK. And she wants to know about how graduate engineers, people who've recently qualified, can get involved to make sure that they feel they're contributing to the challenges posed by COVID. And she's enjoying both of your contributions as well.
Yeah. I think the first thing which we do as an engineers, and when we have freshly graduate engineers, we put them in hospitals. We ask them to spend 2 to 3 months with doctors, live their life, understand actually what's happening. Don't go by textbooks, but go by the real life experience, understand the problems faced by them. Then it becomes quite easy to develop solutions from them. So my advice would be that only that you go and work with any of NHS hospital, volunteer with them, spend some time, and don't ask doctors what they need. Just see what actually they need, where things are going wrong, where patients are. Whom, as an engineer, you can think that this problem could have been solved, but it still exists. Just see how that problem can still be can be solved after 2-3 months when you go back.
It reminds me of listening to Bob Langer, who is an extraordinary engineer at MIT, who won the Queen Elizabeth Prize for Engineering for his pioneering research and drug discovery. And who, of course, is also behind one of the companies that's in the forefront of this new wave of mRNA vaccines. And he said that he started out as a chemical engineer working, I think, in oil and gas, and he just spent time wandering around hospitals, looking at what are the issues people are facing, and that was the start of his stellar career. So great advice there, Nitesh. I've got another question for both of you this time from Jo Hartnell, who is one of the Academy's Leaders Scholars. So these are fantastic undergraduate students. And she's asking, I'd be interested to hear the panel's thoughts on what they anticipate will be the long-term impacts or legacy of this pandemic on the engineering industry and on life more generally. Big question. So Richard, why don't you start?
Well, I wish I had a crystal ball on that one. I think let me talk a little bit about long-term impacts and then long-term legacies. The long-term impact, I think, will be substantial. If we look at poverty, particularly in lower middle-income countries, COVID-19 is driving millions of people into poverty and below the poverty line. Indebtedness is rising rapidly. Unemployment, closure of small businesses. There's no vaccine against poverty. There's no vaccine against indebtedness. And so we are facing chronic, severe consequences for years to come. And they will affect lower middle income countries much more severely than they will affect high income countries. So I think we've got quite an agenda of important work to be done on those chronic consequences of COVID-19. I think the key kind of legacy issue is that we use, we shouldn't waste the opportunity of a big crisis to look to the future. And so a legacy that really uses the COVID-19 response in the field of pandemic preparedness to be much more ready and effectively organized for the next pandemic. I think that would be the single most important legacy we could hope for.
Thank you, Sir Richard and Nitesh, and also just flag that Joe's given a follow-up question, which is asking about, how is this going to change our view of the professional skills and attributes that we're going to need, particularly in engineering, to ensure greater pandemic preparedness in future. So Nitesh, your thoughts on either or both of Joe's questions?
Yeah, I think this is again quite interesting questions, because the more and more we are seeing role of software engineers is becoming important. But then this pandemic has brought us down to look into all fields of engineering, and brought us to basics of engineering. That look at the basic physics, and people who understand the most important aspect of engineering side, like again the basics of physical laws, how flows work, how pressure works, how the diagnostic work. Means I still a lot of people talk about AI and other thing, AI ML. But when I see in the field and practically 90% of the solutions do not work, specifically in developing countries, because that kind of infrastructure is not available. So these are fancy terms to use right now, but then to see them working in field, we still have long time to go. So we still need more and more engineers with basic skills who are really good at their core engineering sciences, and then solve, as I'm focusing more on to solve real world problem and understand real world challenges, and who are good at translating the need of not just doctors, but who are good at translating the customer need into engineering requirements, and then able to solve them. I think that's the biggest skill set right now we need with engineers.
It's back to the user-centric design, inclusive innovation mindset again. Now, please do keep your questions coming. I will come back to them, audience, but I want to ask a question of my own, if I may. So I want to refer back to your opening comments, Sir Richard, around the embedded experience that we're going to gain from this, this year of challenge for many of us. And how that shifts our mindset for the future. So, I also think of resilience as a bit like insurance. It just doesn't make you feel good investing in it when you actually secretly hope that you're never going to need it. And perhaps that's one of the reasons that it's quite hard to get it to the top of the political and the public priority list. But as you said, we can't waste this crisis that we're living through. So, what can we do as engineers and as citizens, really, to ensure that the pandemic does result in a better understanding and a better investment in planning for resilience in general, not just specifically our ability to tackle a coronavirus pandemic?
Well, yes, I think that's a very important topic. If you ask people around the world today, are pandemics horrible things which we should work hard to avoid and prepare for the first time in our lifetime, everyone would say yes. I mean, this has been a real wake-up call for everybody everywhere in the world whose lives have been disrupted in an amazing way. Everybody's an amateur epidemiologist. I go to McDonald's and I hear people discussing the basic reproductive number. It's extraordinary. We've all become armchair epidemiologists and armchair public health pundits because of this pandemic. So I think the professional community, both medical and engineering, has to really use this to say, hey, we're getting through this one. The consequences have been enormous. The damage has been huge. The next one is going to come, and we can explain why that is. And we must get ready for it, and we must be prepared and set up an agenda that the public can understand and focus on, of the particular things that we need to do to be better prepared. And they range from, the discovery of broad spectrum drugs and vaccines through to the better mask. At the first sign of the next pandemic, everybody around the world puts on a comfortable, highly protective kind of a face covering, which doesn't fog up your glasses, and doesn't make you feel too hot and uncomfortable, but does the job. And that single thing slow down the next pandemic by an enormous degree. And of course, there are many other examples. So really make that argument and keep making it. And the people who control government expenditures and people who control private sector expenditures and investments should be more receptive to that now and in the coming year than at any other time in our life. And I think we should be able to powerfully make that argument. And then beyond that, as you say, resilience and preparedness for either probable shocks to the global system, or in the case of climate change, a shock to the global system that is well underway and is in no doubt. But still, we are doing far too little, and we tend to be whistling in the dark. And hopefully the COVID experience can knock us off that track into something much more dynamic and energetic, which brings us into the whole question of investment in green energy versus investment in fossil energy, which is a hot topic as countries emerge from this fiscal crisis and think how to allocate public resources.
Thank you, Sir Richard. And Nitesh, your thoughts on this?
Yeah, I think when Sir Richard was speaking, I was just, this story was playing in my mind that isn't we have gone through, even in last 1 decade, I can look at in India, we had, just before COVID, we had Nipah virus got in. We had other pandemic, these are not pandemic, but small epidemic have kept on happening across the globe. Just wondering that, did we really not learn from them? And if I look at, actually we didn't, few pockets actually did learn and were prepared, but it's still as a community or as a human society, we didn't learn much from that. Even seeing how it works, seeing what we needs to be done. We lost life then also, but still. So I'm a bit more confused that we will really learn anything from it, or it will again become the same thing. So I don't know what to answer on this. Yeah.
But just coming in quickly on the back of that, on the positive side, I agree absolutely with what you just said, Nitesh. But on the positive side, I think it's very clear that many countries in Africa have actually done better so far with the COVID-19 than countries in Europe, partly because they're used to fighting infectious disease. They're fighting malaria, they're fighting HIV, they're fighting tuberculosis, and they're familiar with what the public has to do in collaboration with the government to tackle these things. And in some cases, they have the workforces and the infrastructure to actually do what needs to be done in the field. And the most striking example of that, I think, is East Asia. Why have East Asian countries done so much better? Now, that's a complicated question to answer, but one of the answers must be that they have kind of muscle memory, intellectual memory from SARS and from MERS. And there's no doubt that across East Asia, the SARS experience and the MERS experience primed those countries in terms of policy and action for the response to COVID-19. So that's kind of good news that there was some learning, and it made a big difference when COVID-19 came along.
Yeah, I think some advanced economies that are used to have healthcare systems that aren't challenged in that way had to rediscover some of the basics around engineering controls as part of infection. But so Nitesh, what my colleague Shane from the Academy, who runs international partnerships, is just asking, as an innovator, what is it that you will take away from this experience that perhaps could be relevant to the challenge we have to tackle climate change?
Yeah, I think what my understanding and what my learning has been now, that localization is a key here, that we have to understand the local environment, local setting, and then innovate according to them. We cannot innovate something and then say it is going to work for globally or going to work everywhere. So we have to spend more and more time in the field, understand the problem, local infrastructure, local problems, and then we have to start innovating towards solving those issues. Umbrella solutions do not work. Again, if I give an example of ventilators again, when everybody started talking about ventilators in India, we produce now so many ventilators we have. Almost we don't need more ventilators for next 10 years. But I spend most of my time right now in field training doctors, working with doctors. 90% of those ventilators are then not working or they are packed because hospitals do not have either infrastructure or people who can use these devices. So these are innovation where public money has gone into, but then these are of no use, and long term these will become garbage after some time. So we have to understand the local context much, and then design appropriate solutions from them. Other thing, as Richard was saying, I can say the positive side of this COVID is I can see more and more local supply chain are becoming crucial, and more countries are becoming reliant on their own production facilities, specifically for really critical supplies, either it is drugs or it is devices. And all countries are trying to produce these really important material by themselves. And this is a good opportunity for everyone across the globe to design to adopt these solutions for their local setting. As again, I'll take bits from Sir Richard's, that you design a mask which is appropriate for that local settings, local culture, local values, which fits into that environment really well. You can take example of a mask which is designed well with a burqa. Mm-hmm. In India right now, we have a lot of designer masks, mm-hmm. which go well with traditional Indian clothes. You can get matching masks here, mm-hmm. with the clothes. So it becomes a fashion trend. So and these are also innovations. So innovation does not always need to be really complex engineering solution. It can be a simple thing, but highly important and making a big impact.
That's a brilliant note to end on. I'm going to be very cheeky and ask you each one last quick question that I'm going to ask for very short answers to. And the question is there a personal learning or insight that you take out of 2020 into 2021? Nitesh or Sir Richard, whoever would like to go first?
Yeah, I think Sir Richard would be a better person. I always go behind him.
Sir Richard, I'm afraid spotlight's on you again.
Personal learning. I think the value of bold action, the value of quick action, the value of international collaboration and acting together, and the value, which we haven't touched on so much, of public-private partnership and government and industry co-investing in these issues we've been discussing.
Brilliant, thank you. And a very short thought from you, Nitesh.
Yeah, I think the biggest personal learning for me has been during this pandemic is that if we really want to solve a problem, there are always doors available. As Sir Richard said, it is either public, private, non-profits, and it's really amazed me that how if you try hard enough, everyone is trying to help. Yeah. And because everyone knows that if this problem does not get solved, or a problem global problem like this, now we are seeing COVID, but then climate change, if these problems are not solved, these are going to impact everyone. And I'm seeing seriousness at all scale, at all level, and even the public awareness. So I'm really, my personal learning is that only that do not hesitate to knock on our door, and everybody's ready to help.
Well, that's amazing that we managed to end on an optimistic note. It's a sobering topic. It's serious stuff. and you've done a marvellous job. Thank you so much to our wonderful speakers for helping us better understand what pandemic preparedness really means and the role that engineers can play in supporting that. Thank also to the questioners and those who've enjoyed listening to us. If this dialogue has sparked your interest in what the Academy is doing on COVID-19, please do have a look at our website. On COVID response, you'll see links to the Engineering X Pandemic Preparedness programme we've been talking about. And stay tuned for further critical conversations on our LinkedIn page. Thank you so much, everyone. Stay safe and goodbye.
Thank you. Goodbye.